Okay, so it's called a TET smell because of tetralogy FLO. But it is a hypercyanotic spell due to the increase in the right to left shunting. But you can have a hypercyanotic spell with any right to left shunt. But it is specific to tetralogy FLO because with tetralogy FLO you have a right to left shunt naturally. So the problem with tetralogy FLO is that you have an increase in the right side pressure, which is shunting the blood from the right side of the heart to the left side of the heart. So that means that it's shunting unoxygenated blood over to the left side. So you have a hypercyanotic spell anytime there's an increase in pressure, even more so on the right side of the heart. So examples of that are when the child's having a BM. So when your child's having a bowel movement, what do? They bear down and they end up holding their breath. So holding their breath causes an increased pressure on the right side of the heart. So that's increasing the right to left shunt. Are y'all with me? When they're crying, what are they doing? Putting pressure in the thoracic cavity, putting pressure in the lungs. During feeding, what do they have to do? Hold their breath. So they hold their breath and they drink and then they go. So it's also increasing the pressure on the right to left side. So there's already resistance on the right side, but we're increasing that resistance even more. So that shunting is happening on an even greater amount. Are y'all with me? So if the pressure increasing on the right side is what the problem is, then what do we have to do? How can we eliminate this? Increase the pressure on the left side. So there's a few ways we can do that because we want to equal out, we want to increase the pressure on the left side so that we can push some of that unoxygenated blood back over and decrease the amount of unoxygenated blood coming back this way because it's going in the path of least resistance. So if we increase its resistance on the left side, then it can't push as much unoxygenated blood over to it. So y'all with me? So one way we do that is we put the baby in a knee chest position. Put the baby in a knee chest position. So if we do that, then we are increasing the vascular resistance on the left side. We're increasing systemic vascular resistance. You're increasing systemic vascular resistance. So what does that mean? Systemic vascular resistance. The body. The body. How much the left side of the heart has to push against to get the blood out. So if we increase the amount it has to push against, we're increasing the pressure on the left side of the heart. Does that make sense? Ryan, I know you just came in, but will you come up here? Okay, so Ryan is obviously stronger than I am. Okay, so he is push against my shoulder. So he's naturally going to push me over. He's the right side, I'm the left side. Go ahead, keep pushing. So he's automatically going to keep pushing on me, right? Now, what if he pushes even harder? I have no choice but to go with him, right? But what can I do to get back at Ryan? I'm going to increase the pressure that I'm pushing against my baby. Does that make sense? So the only way for me to push it, I have to push against him to keep him from pushing against me. Are y'all with me on that? So you do want to, so whatever is occurring, we want to stop. Can you keep the child from pooping? No. But if they're crying, what can we do? Soothe them. We want to shush them. We want to try to get them as calm as quickly as possible. What can we do with their food? Give them a break. Give them a break if we notice that that's occurring. What if mom knows every time that the baby has a bowel movement that they have a hypercyanotic spell. We can have a stool softener, that would help. We could go ahead what do babies start doing when they're having a bowel movement? You see them at the dinner table and they go. Okay, so when you notice that happening, you get baby, you automatically put them in the knee chest position. So you get them and you go ahead and put them in that position. When they're crying, you go ahead and put them in that position. Is oxygen going to help? Yeah. We're having a decrease in oxygenation in the body, so we have an increase in the demand of oxygen. So we got to increase the supply of the oxygen. So we can go ahead and put oxygen in their nose. They may walk around with oxygen, and what could we do to the oxygen if they go ahead and walk around with it and it's in their nose already? Bump it up a little bit. But is oxygen going to stop the pathophysiology of the hypercyanotic spell? No. So what is your primary? Don't pass go, don't collect $200. Increase the pressure on the left side of the heart by doing what? Knee chest position. Now let's say the child is a little bit older and they are ambulatory and they are waiting. We are trying to get them a little bit older to have their surgery. They haven't had their surgery yet. When they feel that coming on, they feel that pressure and that hypercyanotic spell, they'll go ahead and squat themselves. But let's say little Sally over here has not had her surgery yet. And she is not ambulatory. Man, that's wrong. What could I do with Sally? Can I say, Sally, get in your chest position? I'm going to put her in. So if you'll put their knees up on their chest and slide them down, which she's not going to do, you'll automatically get them in the knee chest position. Do we want her head elevated or do we want her flat? We want her elevated. What does laying flat do to the pressure in the thoracic cavity? Increases it. So by decreasing the pressure in the thoracic cavity, we are decreasing the pressure on the right side of the heart. Are y'all with me? It's a knee chest position. Now, you're still going to put oxygen on the baby, but you're going to put oxygen on the baby after you have put them in the knee chest position. So Sally starts crying. She starts turning super blue. Now Sally walks around blue, but now she has turned from lavender to deep purple. And so I'm going to, and she's turning gray, a gray color. So I'm going to pick her up. I'm going to get her in the knee chest position. Now I'm going to do what? I'm going to be shushing her while I'm putting the oxygen on. Now this is an issue, especially with LPNs, because in real life, if Storm's coding, I'm going to be working on Storm while I'm reaching for this and I'm grabbing that and I'm putting this on her and I'm doing so and so. So you're like, well, I'm going to do all of those things, right? And you're going to be doing them all at one time, right? I'm going to be putting the head of her head's bed up. I'm going to be grabbing her oxygen. I'm going to be doing all this stuff all at one time. But when we're asking you on the test question, we're asking you for what? The first thing you're going to do. You're not pass and go. You're not collecting $200. I'm doing this one thing. So that's very difficult because you're like, hey, I'm going to put oxygen on them. Like, both of those are the right answer, Miss Campbell. Yeah, but it's not. I'm asking you for the first thing you're going to do when we're asking you the test question. What does morphine do for our cardiac and respiratory patients? It relaxes and it also decreases oxygen consumption. It decreases oxygen consumption. So you do not give your chest pain patient necessarily morphine for their quote-unquote chest pain. They are. But the main reason you're giving it is because it decreases their oxygen consumption. And our oxygen demand has gone up because they're ischemic. So now we have to get more oxygen to them. Are y'all with me? So we may give this baby, you may have an order for morphine. And you're like, well, the baby's not hurting. But are we giving the baby morphine in this particular instance because they're hurting? No. Are y'all with me? Most of the time they have in the morning, you have vasodilatation in the morning. That is why boys have issues in the morning, because we have vasodilatation. When you have vasodilatation, that is going to increase. Where are the veins going to in my heart? The right side. My veins are going to the right side of my body. So if I have vasodilatation, then I have an increase in blood flow going to the right side of my heart. So and I have a decrease in systemic vascular resistance. Because if I have vasodilatation, the left side of my heart is not having to pump as hard. So we have an increase in the morning, we have an increased pressure on the right and a decreased pressure on the left. So what is going to increase? My shunt, my right to left shunt. So the children have an increase in hypercyanotic spells in the morning. Are y'all with me?
You say increases in the morning?
Mm-hmm. Increase and that is due to vasodilatation that occurs in the morning. So, and that vasodilatation causes a decrease in systemic vascular resistance and an increase in venous return to the right side of the heart.
And you said that's called what?
What now? In the morning, you have vasodilatation. That vasodilatation causes a decrease in systemic vascular resistance. So we have a decreased resistance on the left, but we have an increase in venous return. So we have an increase in pressure on the right side of the heart. So the parents need to be aware, and you need to be aware if you're caring for them in the hospital, that there is an increase in hypercyanotic spells in the morning. So you need to be prepared for it in the morning. So when you go and wake that baby up in the morning, you need to be aware that you may be stimulating a hypercyanotic spell. So you just need to be prepared for it in the morning and watching for it with your eyeballs.
Pathology for the tetralogy is one of the most common congenital heart defects. It has four main features: ventricular septal defect, or VSD, overriding aorta, pulmonary stenosis, right ventricular hypertrophy. This is a view from inside the right ventricle. This is a ventricular septal defect, commonly referred to as a VSD. A VSD is a large hole between the left and right ventricles. This allows abnormal flow of oxygen-poor blue blood into the left ventricle. The right ventricular outflow is obstructed, which can limit blood flow to the lungs. This is referred to as pulmonary stenosis. The aortic valve is enlarged and overrides the VSD, which makes it easier for oxygen-poor blood to enter the systemic circulation. The right ventricular wall thickens or hypertrophies due to outflow obstruction. Oxygen-poor blue blood, oxygen-rich red blood, mixed purple blood. This is VSD blood shunting. This combination of abnormalities can result in decreased oxygen in the systemic circulation, sometimes resulting in patients appearing cyanide or a bluish appearance.
And this is one of the more common defects. The tetralogy of Fallot. Transposition of the great arteries. We used to call it transposition of the great vessels. So I may call it transposition of the great vessels, but it's the same thing. So where is your aorta supposed to come off of? The left. The aorta is supposed to come off the left ventricle. Where is your pulmonary artery supposed to come off of? The right. So in this particular situation, your aorta comes off of your right ventricle and your pulmonary artery comes off of your left ventricle. So your oxygenated blood comes from the lungs, goes through, and then goes back to the lungs to be oxygenated. The blood goes out, your unoxygenated blood goes out to systemic circulation and then comes back to go back into systemic circulation. So unoxygenated blood stays in systemic circulation unoxygenated. The oxygenated blood stays in pulmonary circulation and stays oxygenated. So this is a lethal arrhythmia. This is a lethal defect. The only thing that keeps the baby alive is the ductus arteriosus and the foramen ovale until they can have surgery. So what are you going to give this baby? Prostaglandin. And you're going to maintain them until they can have surgery. Because in the cath lab, can we cut the aorta and the pulmonary artery and switch them? So the only thing we can do is to keep them alive with prostaglandin until they receive their surgery. And they're going to have surgery within the first couple of days of life. Very simple. They can have stenosis of their new valves, and they can have scar tissue that includes those new areas. So our oxygenated blood goes out, gets oxygenated, comes back, gets oxygenated, comes back. Our unoxygenated blood goes out, comes back, goes out, comes back. So the only thing that keeps the baby alive is the PFO and the PDA. Once again, that's a blue baby, an example of a blue baby. And then once again, it's a lethal defect, so they have the option to let the baby live its short life and expire. So truncus arteriosus is the pulmonary artery and the aorta fail to separate. So they are one. There's supposed to be two vessels, they're one. Once again, this is life-threatening because what do we have going out to both? Unoxygenated blood. So we have too much volume going to the lungs and we have unoxygenated blood going out into systemic circulation. Now, how severe it is depends on how much of this is separated. They may be one vessel down here but separate out into two. Or they may be one blood vessel all the way up to the arch. So the severity depends on the severity of the lesion, but it is life-threatening, and once again, they have to have surgery very, very quickly. This baby, the PFO and PDA don't help this particular situation, so this baby does not need prostaglandin. Total anomalous pulmonary venous return. Your pulmonary vein is supposed to come off of the left side, and it comes off somewhere on the right side. So our oxygenated blood is supposed to come over here to go out into systemic circulation. However, it comes off of the right. So if our oxygenated blood is emptying into the right side, where is it going to go? Back to the lungs to get oxygenated. So what are we lacking? Oxygenated blood. So once again, this is a lethal arrhythmia, a lethal defect, and they have to have a patent PDA. They have to have a PDA and a PFA. So what is this baby going to get? Possibly. They're going to have surgery very, very quickly, and it is lethal. Coarctation of the aorta. There's a narrowing of the aorta. And it typically happens a little bit past the arch. A little bit past the arch. So this is typically where it occurs. You have the arch and then you have the narrowing right here. So before that defect, the baby is going to be hypertensive. They're going to have bounding, they're going to be hypertensive, they're going to have bounding pulses, they're going to have red tint to their skin and their upper extremities, so their hands are going to be red and hot, their face may be flushed and hot, and then distal to that defect, the lower extremities are going to be hypotensive. So they are going to have be hypotensive in their legs. They're going to be pale or blue colored, their legs and feet are. They're going to have a prolonged capillary refill. They're going to be cool to touch. And why is that? Why are our extremities showing a decrease?
Is it the last?
We have a decrease in blood flow distally. We have hyper blood flow proximally.
With that, would they end up having like increased pulmonary vascular flow because of the fact it's all backing up?
So you can have this baby still at risk for congestive failure. They are going to have signs. They can have nosebleeds, they can have headaches, they can have blurred vision. What's the problem with having blurred vision and headaches if you are 2 weeks old? You can't tell anybody. You can't say, hey, babe, my head's hurting like really bad. And I'm kind of getting like this blurred look to everything. So they're just going to cry a lot. And what's crying going to do? Increase everything. They are now, before the baby leaves the hospital, they assess for this. So if I'm hypertensive above and hypotensive below, what do you think one of the interventions is? Position. I'm going to, you can position the baby with their head a bit elevated, and that will decrease the pressure in the thoracic cavity in the head, yes. But you're going to get blood pressure and vascular assessment in all 4 extremities. Blood pressure and vascular assessment in all 4 extremities. And they have to do that, I believe, before each baby leaves the hospital. Now, that's part of a cardiac workup. But yes, cardiac patients and respiratory patients should always have their head a bit elevated. You should never lay a cardiac patient or a respiratory patient flat, and you most certainly don't Trendelenburg anybody. It's like the patient's like drowning in their own, secretions, and you walk over and lay their head a bit flat. The cardiac patients and respiratory patients need to be elevated at least 30 degrees. What does that do for my patient? Decreases pressure, cardiac workload, it decreases our cardiac workload, it improves circulation. It decreases pressure in the thoracic cavity, which means that my heart doesn't have to work as hard, and what else doesn't have to work as hard? My lungs. So it improves oxygenation and cardiac performance. Are y'all okay with this? So we know we have this lesion. What do you think we're gonna do to it? What's it, before we do surgery, what could we do? Cath lab. So if the lesion is not super tight, so they'll go in, they'll get pressure on this side of the lesion, they'll advance the catheter and get pressure on the other side of the lesion and see how severe that area is. If it's not super tight, what could they do to it? Balloon it open. What would be the problem though, if it's super tight, what would be the problem with putting a balloon in it? They could tear the aorta, and now we have a, emergency surgery that we have to get to. So let's say it's too tight. They're gonna go in through surgery, they're gonna remove that lesion, so they're gonna cut right before it, and then they're gonna cut right after it, and then they're gonna put a graft in that place, so the patient will have an aortic graft. Now, what do you think that patient's gonna have to be on? Blood thinner. What else? What is it? Not with the graft, you don't. Antihypertensive, they're probably gonna be on beta blockers and probably on some type of, blood pressure medicine. So a beta blocker is gonna decrease how, the heart rate, it's gonna decrease the heart rate, so the heart is not gonna beat too fast. And then we're gonna have vasodilatation so that the patient the heart doesn't have to push against too much of a gradient. Does that make sense? So they're typically gonna be on blood thinners, beta blockers, and antihypertensive medicine. Hypoplastic left heart, is everybody okay? Am I going too fast? Hypoplastic left heart. This is where the left side of the heart does not form completely. So they typically have a very small ventricle. They could have a very small atrium, and they have a very small aorta. And what pumps our blood for us to our body? Left ventricle. So if there's hardly any ventricle there, then we hardly have any circulating blood flow through the body. So one way we can help get blood to the body is to keep the patent ductus arteriosus and the foramen ovale patent. This is life-threatening. They have to go to surgery within the first few hours if they can. It'll be their first surgery will be their first day of life, typically. This used to be a death sentence. There used to not be anything we could do for them except for they're born and we do comfort care until they pass away. They have developed surgeries. It's a 3-stage surgery. I'm not going to ask you the surgeries. I think the surgeries are in your book, but don't try to memorize the surgeries. I just want you to be aware that it is a stage surgery, and the first one is within the first day of life. So if they make it through their first surgery, their outcome is very good. However, when they typically pass away is with their first surgery or shortly thereafter. Why would that be? They're only a few hours old. So the mortality and morbidity is very high the younger you are. So is there any way for us to get this baby older for them to have their surgery? No. So after their first surgery, the outcome is much better. Oldest child that I could find several years ago was 7 years old. Is the oldest one. But we had a family in our church that their child was born with this. And there is a gentleman from the hospital that the child was having their surgery at. And he calls people with this defect and say, and he was 25 years old a couple of years ago, and that's the oldest person I've ever heard of. But he's in medical school, and he has had all 3 surgeries, and he's lived to be 25. So that's pretty darn good. The stage surgeries make it where the person lives off of their right side, and it has to do with changing the pressures in the heart. So it's very, very complicated. And your heart is about the size of your fist, thereabouts. So just imagine a 1-day-old's fist. That is what that surgeon is working on that first day. So he is a neonatal cardiovascular surgeon. That just blows my mind. So they're doing all of these things to make it where the person lives off of their right side. Once again, don't try to memorize the pieces and parts of the surgery. Are y'all okay? Okay. So I've had several people ask, so what the heck am I supposed to know about these defects? So I want you to know where the blood's going from, where the blood's going to, and what that defect means for that baby. So for instance, with the septal defects, where is my blood supposed to be going from? Where is it supposed to be going to? And what that means for the baby. So my blood is supposed to be going out to the lungs, coming back and going out into my body. However, my defect is between my septum. So what does that mean for my baby? That means that my blood is going to shunt over from the left to the right and go out into pulmonary circulation, which means, what does that mean for my baby? That means that they're going to have too much blood flow to their lungs. Okay, so that's what I want you to know. There are a couple defects, like the pulmonic stenosis. Depending on the severity of that defect, the child is definitely going to be short of breath. If it's super, super tight, they're probably going to be cyanotic. But they're definitely going to be short of breath. But what are all of the defects going to have in common? Heart failure. So the main thing I want you to focus on are the signs and symptoms of congestive failure and what you're going to do for that congestive failure. I don't want you to get bogged down on, okay, this is going here and my baby's going to have left heart failure and blah, 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 blah. I want you to look at congestive failure in general and know that if you have a baby with a congenital heart defect, you're looking for congestive heart failure and you're taking measures to prevent the congestive heart failure from getting worse. Because if the baby you may not be taking care of somebody getting prepped for surgery, but what could you have on the floor? So with the congestive failure, my baby with that congenital heart defect I'm probably not going to be prepping them for surgery at Highland, right? Because do we have a pediatric cardiovascular surgeon in Highland? No. Right, so I may not be having that, but the baby is going to be at home and mama's going to be managing that congestive failure. Baby gets sick, or for whatever reason, the congestive failure gets super, super bad, super, super quick. What's mama going to do? Are you going to go to the emergency room, right? And who's going to be taking care of them? You are. So you have to know that what these defects are and how to manage a congestive failure, because they're at home and they may be brought in with a complication and not so much, I'm getting this baby ready for surgery. Now, you may be a NICU nurse and this baby's just born and they're brought into the NICU and you do have to prep them for surgery or prep them for transport and manage their congestive failure, but that's not always the case. They may be brought in because they may have a infection and they're brought in. Does that mean if they're brought in for an infection, does that mean you ignore the fact that they're at risk for congestive failure? No, you still have to be on top of it. Oh, they're waiting for surgery, they have this. I still gotta be on top of the congestive failure. So do you let this baby that has the infection and has the congenital heart defect, do you lay them flat? No. What's your primary concern gonna be when you go in the room? What are you gonna listen for over and over and over and over again? Lung sounds. And what kind of lung sound is this baby gonna have? Wet. They're gonna be crackly. What kind of cough are you anticipating and looking for? A wet cough. Can I have a wet, unproductive cough?
Yes.
What does that mean? I hear it and it's all crackly and nasty and it's all right here and baby can't ever spit it out for me. It just doesn't come out. So what does that mean? That snot is in their throat. It's built up and it's too thick. So I gotta do something to thin it out. Can I have a wet, productive cough? What does that mean? They're able to get it out. Which one do we want? We don't want a wet cough at all, but which cough would we rather have? The wet, productive cough rather than the wet, unproductive cough. Are y'all with me? So we could have, when we talked about before, when the people coming through the room, going out into the hallway, we can have buildup of blood and overflow of blood for many different reasons. But they're all at risk for congestive failure for one reason or another. If I'm sitting here and, or you're sitting at the nurse's station and you're hanging out doing the charting and all of a sudden somebody goes into ventricular tachycardia, what are you gonna do? Hop up and start running. So do I need the same cardiac output when I'm sitting at the nursing station charting as I do when I'm up and running? No. So your heart, an adult heart, is able to change its stroke volume. So that means it's able to change the amount of blood it's pumping with every beat. Babies can adjust that. So their cardiac output, if we remove the alteration of the stroke volume, the amount of blood that happens with every beat, we take that out of the equation. The baby's cardiac output is reliant on the heart rate. So if I have a need for an increase in cardiac output and I'm an infant, what has to go up for me to get that increase in cardiac output? Heart rate. So if I have an infection or a fever and that makes a need for an increase in cardiac output, what's going to go up? Heart rate. What goes up with my heart rate? Respiratory rate, need for oxygen. So if my respiratory rate goes up, my heart rate goes up. If my heart rate goes up, my respiratory rate goes up. So what is baby spending all of their energy doing? Breathing and maintaining their heart rate. So even an infection can cause an increase in the heart rate and respirations. A fever can cause it. Stress on their body of any kind can cause it. And the thing that has to go up with it is their heart rate. So some early signs. Do we want to get baby when they're right down here and they're having retractions and grunting and nasal flaring? We want to catch them over here, right? Okay, so what is retractions, grunting, nasal flaring, and tachypnea? What is the baby in? Respiratory distress. If you have waited that long, your baby is circling the drain. We want to get them way over here. So my baby is gonna be, irritable because they don't feel good. Why would I be diaphoretic? Because I'm working so hard to get air and my heart rate. They may not be diaphoretic. Do I have to have great big beads of sweat dripping off of my forehead to be diaphoretic? What could I feel like? I could feel damp. How do you know if I'm damp or not? You're gonna touch me. So if you have, if Storm is on the table, if she's laying in her bed and she looks like she is in distress, so she's pale, she's tachypnic, I look up, she's tachycardic, what am I gonna do to her? Am I gonna say, now, Storm, are you diaphoretic? Okay, I'm gonna touch her. If I have my glove on, am I necessarily gonna be able to feel this diaphoresis? No, so that's one reason why, you may wanna take your glove off and touch her to see if her skin feels damp to you. I'm gonna have a wet cough. It says productive, the book said productive, but it's gonna be wet. It may or may not, I may or may not be able to get it up. So I would rather it say a wet cough than a productive cough. Productive means that I'm able to cough it up. Why would I have abdominal distension and edema? The right side of my heart is, I'm having right-sided failure and it's building up, and that where, if we have pressure in our venous system, where is it gonna push that fluid out into the tissue? So I could have swelling. They're not typically gonna have swelling in their face first. It's typically gonna be later on. It's typically gonna be in their feet, and it's gonna move its way up. The edema is gonna move its way up. What might my abdomen feel like when you touch it? If I have swelling in it? Tight. Is it necessarily gonna be painful? No. It's probably not gonna be painful, but it's gonna feel tight. What else could I get if I'm worried about my baby having failure, congestive failure? What could I get every day? A weight. And if I have fluid accumulation, what is my weight gonna do? It's gonna go up. What else could I measure on my baby? Abdominal growth. Do I have to have an order to daily weight my baby? No, I do not. But I could daily weight my baby till the day is long. Nobody has to tell me that I can or can't do it. But what do I have to get in order to make sure that everybody else gets a daily weight in order? So if I want to make sure I want a daily weight, and I think daily weight's important, I get it for the 3 days that I'm on shift to make sure that the person tomorrow gets the daily weight. I got to ask the doctor for an order. Anybody have any questions about any of this? How can we conserve energy? Prioritize. So we are going to cluster care. We're going to prioritize our care, and we're going to cluster our care. What does cluster care mean? I'm going to get everything I can. I'm going to do everything to baby. And then what am I going to do to baby? Leave them alone. I'll leave them the heck alone, and they're going to rest. So are we going to tell the 4-year-old that they can't play? No. But what do we want their play to be? Calm, quiet play. Do we want them up dancing to whatever's on the TV? We want them sitting. And do we want them laying down? No, we want them sitting up in the bed. So we're going to elevate their head of bed so that they can relax, so they can lean against it, but they can still play. So we're going to get them dinosaurs. We're going to get them coloring books. What is a 12-month-old, 18-month-old going to do to the coloring book and the crayons? They're going to eat them. So you have to make sure that what you're giving them is appropriate. They're gonna eat cards. They can't read the card, first of all, but they're gonna eat the card. A board book would be good for mom to read to them, because they can chew on it. You wanna give them stuff that is age appropriate. But we wanna have them quiet, and we wanna have them still. What if they wanna go to the playroom? Can they go to the playroom? How can they get there though? We're not gonna ambulate them down the hallway. We're gonna put them in a wheelchair, we're gonna carry them, and we're gonna get them to the playroom, but what do they need to do in the playroom? Just sit. What can we do with their oxygen? Do we just say, oh, while you're in the playroom, you don't need your oxygen? We're gonna get it and we're gonna wheel it with them. If there's, some playrooms will have oxygen connections in the room, but how are we gonna get the oxygen from the wall to the baby? We're gonna put extensions on it until the oxygen is on the baby, or we're gonna wheel it with them and sit it by them. You don't say, oh, I'm gonna take your oxygen off and I'm gonna ambulate you to the playroom. You're gonna do what you can to take the oxygen with them, and you still want them sitting. What about with the nutrition support and the energy conservation? What is the baby using when they eat? Energy. And what is all of their energy being spent on? Breathing and heart rate. Heart rate. So, what could we do with their food to conserve their energy? Small, frequent meals. I am gonna have longer rest periods in between, and it's also not gonna use up all my energy trying to eat 4 ounces when I can eat 2 ounces, and then in a couple hours, you're gonna give me 2 more ounces, rather than trying to eat 4 ounces at one time. What else could I do? What do we typically do with older people and fluid? Fluid restriction. So your baby may be on a fluid restriction. So if they're getting formula, how do you restrict their fluid? Make it more concentrated. So we're going to make the fluid, rather than putting it in this much water, we're going to put it in this much water. So we're going to concentrate their fluid. So they're still getting the calories and the nutrition from it, but they're not getting as much volume with it. And the nutritionist and the physician have this long equation that they use to make how many calories they want based off of the amount. You're not going to have to do that equation. The pharmacy or the physician or the nutritionist is going to say, you're going to get X amount of this amount of formula. So you may have to calculate how many milliliters you're going to give, and then some pharmacies aren't even going to let you do that. They're going to say, this is your formula, I've mixed it for you, and you're getting this much. Yes.
So is breastfeeding completely out?
They will calculate that in with it, if the mom wants to. And I haven't been in a situation where the mom was breastfeeding. We had the concentrated formula that we gave. So I don't know if that was something she talked to the physician about, but typically in any defect with the child, if the mom wants to breastfeed, they work that into the nutrition of the baby. They don't just say, no, you can't do that. They say, let's see what we can do to let you do that and still maintain what the child needs. So what if the doctor says he wants 4 ounces of formula every 4 hours, but when the baby ate, they only got 2.5 ounces down? What could we do with the other remaining formula? Do we say, oh, she couldn't get that down? What is it? What is it? Try again. They typically give you 30 minutes to get the fluid down. So she was saying try again. So we could let the baby rest for a few minutes, but they typically give the baby 30 minutes to eat the formula, to consume the formula. After that 30 minutes is gone, you're done. So they typically put it down in NG2, so that you'll gavage the remaining formula. So you can't just say, oh, couldn't get that down. Because what are you taking away from the baby if you don't finish the formula? The nutrition. And they need that nutrition because they're spending all of their energy just laying there. So if you take away that, then you are taking away their calories they need for breathing. What if, let's say I have an older child and they are on fluid restrictions, what could I give the baby instead of juice? Let's say they're thirsty. What could I give them instead of juice? They give them popsicles. What's another thing that's even less than a popsicle? Ice. I could give them ice chips. Now, the problem with ice chips is you give them a cup, your cup, you bring in, and I say, okay, here's your ice chips, and I fill this cup all the way full. What's that baby gonna do? So they just made a meal out of their ice chips. What is the purpose of the ice chips? You take a bite and you're wetting your mouth. So it's giving them something in their mouth to wet their mouth with. They're thirsty, but you can't allow them to make a meal out of it. So do you fill the cup all the way up? And you give them just a little bit, so they have to call out again if they wanted more. Does Mamaw get to go fill the ice cup up? No. Because Mamaw comes out with that 500 milliliter ice thing, and so she's going to give the baby a spoon. She's like, well, she's eating ice chips. You said she could have ice chips, but you didn't say she could have 500 milliliter container of it. Okay, so talking about medicines. Why don't y'all take a break and we'll do medicines when y'all come back.
Wait, before you leave, I have an announcement.
Sorry, y'all.
What on this book?